and then toxic effects of drugs. So let's start out with what pharmacology is. So pharmacology is, by definition, the study of the biological effects of chemicals, okay? Drugs are going to be the chemicals that we introduce into our body because we are hoping to promote some sort of a change. Sometimes it is to stop something from happening or to start something from happening. So a lot of different reasons we give medications. When we put drugs into our body, then the body starts a process which is going to be involved with breaking down and eliminating the drugs. Okay. So in the clinical setting, healthcare providers focus on how chemicals act on people, living organisms. Nurses in particular will deal with something called pharmacotherapeutics. Okay. This is just one small portion of the pharmacology as a whole, and that's going to be used to treat, with using these medicines to treat, prevent, and diagnose disease. So clinical pharmacology usually addresses two key concerns, and that's going to be the drug's effect on the body, and then that's going to be the body's response to the drug, okay? When we give a patient a medication, we don't really have a good understanding of how this medication is going to react inside of a person. So some drugs will be considered therapeutic, which means that they're going to do exactly what we wanted them to do. And others are going to cause undesirable and even very potentially dangerous side effects. Usually we call these negative side effects, adverse effects, or side effects of the drug. And we're going to talk more about those. All right, so what is our responsibility in nursing? So our responsibility is to administer the drug. It is also our responsibility to follow up after we give this medication to make sure that the medication has done what we wanted it to do and that now the patient doesn't have any adverse side effects. So we never, ever just give a medication and then don't follow up with the patient, okay? We are also responsible when we're monitoring for our wanted effects and also making sure that we don't get these adverse side effects, that we intervene when we're supposed to make sure that that drug regimen is more tolerable, okay? And it's our responsibility to provide the patient with teachings about the medicine that they're taking, because ultimately, if we're giving somebody a medication, we want them to be compliant with taking that medication. And what we see sometimes is that when patients suffer from unpleasant side effects or things like that, or they don't realize that there's something that they can do to make the side effects better, then they stop taking the medicine. And then that leads to these medical conditions being uncontrolled, okay? And then, of course, we're going to monitor and prevent medication errors. All right, so just quickly, some of our medications are made from natural sources, okay? We can use plants, and then we can use animal products. So animal products are used to replace those human chemicals that are going to be failed to be produced in the body because there's either a genetic problem or some type of a disease. It used to be until recently that we used insulin, which insulin is a medication we use to treat diabetes, that it was obtained exclusively just from the pancreas of cows and pigs. Now we can see that we can get these from other areas, okay? We can do things through genetic engineering, which allows scientists to be able to produce things like human insulin by altering different other things. For example, E. coli bacteria is one way that we can do this now. All right, some of our natural sources. So you don't need to know these for your exam, but we have inorganic and inorganic compounds. Examples of that are going to be different salts, okay, of various different chemical elements. And we know if we use them and introduce them into the body that they can have an effect in the human body. And then we have synthetic sources. So many of the medications that we have today are developed synthetically. And they're found to have a better therapeutic effect on our patients. All right, so a little bit about legislation. So In legislation, we have different rules now that we have to allow our medications to undergo different scientific testing, but it wasn't always that way. Okay. So since 1906 up until the current time, we're still looking at things to try and make medications safer for patients. So one of the things that we've been able to pass is that now drugs have to be scientifically tested. We need to be able to know how these medications are broken down in the body, what makes them therapeutic, and what are those toxic effects that we have that can happen to the patients before we make these drugs legal. This testing process that does happen is going to be controlled by the Food and Drug Administration. So the Food and Drug Administration's job is going to be to regulate tests to make sure that these medications are safe and reliable. They also do all this before these medications are released into the public, and they usually go through several stages of testing. So these things don't happen every night. They take several years. And they also have a hand in really monitoring for medications that may potentially be addicting so that they can determine if they're going to have, certain labels on them that prompt providers to not prescribe these medications as easily. Then we have medication pregnancy category. So this is important for you guys to know. Also, the previous slide, which I forgot to tell you with legislation and the FDA, you need to know that. But this is also important. So the FDA went and designed different categories based upon whether or not these medications would have a harmful effect on the human fetus. Okay. So if you look on this calendar, on this little slide that we have here, we have category A, B, C, D, and X. So A and B pretty much tell us that there have been adequate studies in pregnant women and that has not demonstrated a risk to the fetus in the first trimester. Okay. Once we get to category C, then it's telling us that based on animal studies, we do see that there is an adverse effect on the fetus. So C, D, and X, these are medications that you would not typically see prescribed to a pregnant woman unless the benefits outweigh the risks. Then we have our Controlled Substance Act. This was implemented in 1970, and this is where we were able to establish categories that defined and ranked the abuse potential of different drugs, okay? And really told us that we need to be careful when we're prescribing this medication because it's highly addictive, okay? So this same act also gave control over the coding of medications and the enforcement of these codes to the FDA, the Food and Drug Administration, as part of the U.S. Department of Justice. So the FDA, remember we said, studies and determines their abuse potential, and the DEA enforces their control. So any drug that is known to have a potential for abuse are going to be called controlled substances. So you definitely need to know this as well. These are our schedules of controlled substances. So we have a high abuse potential is a Schedule 1. So that's no accepted medical use at all. So what it means is these medications that fall under this category can in no way, shape, or form ever be used to treat anything in the medical field. And medications that would be, or things that you would see in a Schedule 1 are going to be heroin, marijuana, and LSD. Now, you are starting to see that have been approvals for different states for medical marijuana. So that is the only exception. And you'll see that varies by state to state. And then, of course, your Schedule 2 there, they have a very high abuse for potential with severe dependence, okay? So these are your narcotics, your amphetamines, your barbiturates. And then you can see as you go down the list, these medications, these classes of medications have a lower risk of potential. So you definitely want to know those schedules for your exam and what medications fall under them. Then we have generic drugs. So you definitely need to know this as well. So generic drugs are going to be chemicals that are produced by companies that are involved in manufacturing drugs. Okay. So what does this mean? in a nutshell. Sorry, I forgot to turn. So you have brand name medications and you have generic drugs. So basically, to give you a good example, many years ago, Tylenol created Tylenol. Okay, it was a medication used for fever and pain relief. Well, they did all of the back work behind, researching this medication, getting this medication studied and available. They hired the people to do it. They put a lot of money into this medication. So when this medication was finally approved by the FDA, the government said, well, you can benefit solely from the benefits of this medication. Any profits that you receive, we won't let anybody else make this medication. You can have the patent for it for a certain number of years, okay? Every medication has a different patent. Maybe Tylenol's was 50 years. I don't know that to be the truth, but I'm just giving you an example. After that 50 years is up, then other companies can come in and make that same medication. And now, because they didn't have to hire all the people and do all the research and start this from the very beginning, they can just take what Tylenol already did and just replicate it. So now they can offer these medications at a cheaper price. Okay. In general, when you're talking to your patients about generic drugs, some people may steer away from them and say, oh, no, I can't take a generic drug. I only have to have I only have to take the brand name. I can't take the generic. So just as a rule of thumb, we should always be educating our patients that generic drugs are safe and very cost effective, because they are, okay? They're very identical to the other brands. In some cases, almost all cases, they're cheaper, and they only have subtle differences. So some of those subtle differences that we think about are going to be our bioavailability of the drug. So what is a bioavailability of the drug? So if I give you these two examples here, Tylenol or acetaminophen is the generic name. If we give that by an oral pill, when you swallow that tablet, not all of it makes it to your blood, because we have this special process that happens in our stomach and our liver, and it breaks it down. So by the time it gets into the blood, there's less of it there. So we would say that the bioavailability is less than 100%. However, if we give a patient a medication through IV antibiotics, okay, it's going to go straight into your blood, which means that the bioavailability is going to be 100%, because none of that drug gets lost along the way. So when doctors are prescribing medications to patients by different routes and things like that, the bioavailability of the medication is something that they really consider when they're choosing a dose, okay? So you really need to have a good understanding of what bioavailability is. You need to understand what a generic drug is. And then you also need to understand what that provider, that doctor, or that pharmacist they're going to prioritize when they consider that substitute of a brand name drug with a generic drug. And that's really going to be that bioavailability. Okay. Most of our generic medications may be identical to the brand name drugs, and they're completely safe. They're cost effective, and they only have very little differences. Okay. The only thing that we may see that is a little different sometimes is the binders, and the binders are going to be what we add into the generic medications to put them all together and put them into a pill. It's always going to be the exact same amount of the medication. It has to be the same active ingredient, and it has to be the same active ingredient dose. But they can add other things into it to put that medication together, and those different binders can then act differently in our patients. All right, so over-the-counter medications. So there are a lot of different products out there that are available without having a prescription, okay? And we can purchase these with the intent of self-treating ourselves for some type of a complaint that we're experiencing, okay? You'll see that some of the things that are over-the-counter now were once approved as prescription medications. So you might be wondering what allows a medication to be recategorized as over-the-counter, okay? So the FDA tells us that if clients cannot reliably self-diagnose the condition that medication is intended for, then it can't be made over-the-counter, okay? So that's something that you guys definitely need to know. A lot of our medications earlier that were not over the counter were then later found to be very safe and effective, and now they're available over the counter. And then some of these drugs were just grandfathered in. All right, so as a nurse, you always want to take into consideration many different things related to over-the-counter use, and this is extremely important for you for your exam. So we know that the FDA is currently always testing the differences of these products, okay? And then in time, they evaluate all of them. But some of our over-the-counter drugs have been found to be safe when taken as directed, but then there's other problems that we can see as well. So taking these drugs could mask the signs and symptoms of a very serious underlying disease, which makes being able to diagnose it difficult, okay? Taking these medications with other prescription medications can also cause unwanted and serious drug interactions, and they can also interfere with drug therapy. If patients don't take these drugs as directed, it can cause overdoses. Patients can lose their lives. And then we always want to encourage our patients to, because of all the things that we've talked about just here, we always have to educate our patients that it's really important that even though they're taking something that they were able to purchase over the counter, doctors, nurses, care providers still need to know that they're taking them, because we know they can interfere with other medications and cause other issues. Whoops, sorry. Okay, so the drug label. So our drug label is very important. You also need to know this slide. So that drug label is going to have very specific information on it that identifies a specific drug. We as nurses need to understand how to read that label. We talked about this last week. We need to know the brand name, the generic name, the drug concentrate, and the expiration date, okay? This is important for a variety of different reasons. We also know that some of almost all of our medications that we get are going to include some type of a package insert. So these package inserts can be extremely difficult to understand and read, which is why a lot of people shy away from reading them. They're going to be prepared by that manufacturer, and they're going to contain all of the chemical and study information that led to the drug's approval. All right, so what are our sources of drug information? So we have a lot of different references available that we have access to that can give us information about drugs. So we always want to make sure that we are using a reliable source, okay? So we could always use a physician's drug reference book. We can use something called Drug Facts and Comparisons. We can use any type of nursing drug guide. We can use scholarly journals, and then we can use those reputable internet sources as well. All right, so question. Clinical pharmacology is the study of A, the biological effects of chemicals, B, drugs used to treat, prevent, or diagnose disease, C, plant components that can be used as medicines, or D, binders and other vehicles for delivering medication. So your answer here is going to be A. Clinical pharmacology is the study of the biological effects of chemicals. And another quick question, the generic name of a drug is A, the assigned name to the drug by the pharmaceutical company developing it, the chemical name of the drug based on its chemical structure, the original name assigned to the drug at the start of the approval process, okay, after the patent has expired, or the name that is often used in advertising campaigns. And your answer here is going to be C, the original name assigned to the drug at the start of the approval process after the patent has expired. All right, so moving on to drugs and the body. All right, so what is pharmacodynamics? So pharmacodynamics is basically a study of the different interactions between the chemical components of our living system and then those foreign chemicals that we were talking about, including drugs that we put into these systems, okay? All living organisms function by a series of very complicated continuous chemical reactions that are continuously happening in the body. Whenever a new chemical or a drug is going to enter into that body, then we're going to start to see a lot of these different effects happen. And like I said earlier, some of them are very effective and some of them are unwanted. So, drug action. How do drugs work? So, they are going to work in one of four ways. They can replace or act as a substitute for missing chemicals. We can use them to increase or stimulate certain cellular activities in the body. We can use them to depress or slow down certain cellular activities in the body. And we can use them to interfere with the functioning of foreign cells. So in order for these chemical reactions to happen, we need to have receptor cells in the body. So many drugs, we believe, are thought to act at very specific areas on the membranes, on our cell membranes. We call those receptor sites. So these receptor sites are going to react with certain chemicals, and then they're going to go off and cause that effect within that cell. In a lot of different situations, we're going to have different enzymes that are nearby that are going to be breaking down the reacting chemical, and then they're going to open up that receptor site so that it can be stimulated even further, okay? So you can kind of think about this as how a key works in a lock, okay? So that very specific chemical, which would be the key, is going to approach a cell membrane, and it's going to find the fit, which is going to be that lock at the receptor site. That interaction that then happens between the chemical and the receptor site is going to affect the enzyme system within that cell. Once that enzyme is activated, then it's going to produce certain effects. And it can increase or decrease cellular activity. It can cause a change in our cell membrane permeability. And it can also make changes in cellular metabolism. Whoops. Sorry, guys. I keep moving too slow, too fast, sorry. All right, so pharmacokinetics. We said the pharmacokinetics is going to be the study of absorption, distribution, metabolism, which is also referred to as biotransformation and excretion of drugs, okay? So in clinical practice, pharmacokinetics is going to consider how, the onset of a drug, how long it takes to see the beginning of that therapeutic effect. It's also going to determine and tell us what is the drug's half-life, what is the timing of the peak, okay, effect, which is how long it's going to take to see the maximum effect of the drug. It's going to look at the duration of the drug's effect, which means how long the patient will experience the drug's effect. And then it's going to look at metabolism or biotransformation at the site of excretion. I'm going to talk a little bit more about this. All right, so we need to know about a few things. So critical concentration. Critical concentration is going to be the amount of a drug that is needed to cause a therapeutic effect, okay? A loading dose is going to be a higher dose than is usually used for treatment. So some medications that we give have a prolonged period. Okay, so if the effects are needed quicker, they might a prolonged period to reach that critical concentration. Sorry. So if we need effects to be quicker, then we give them a loading dose, which is a drug used to increase the strength of the heart contractions. So digoxin is an example of that. So it's a medication that we use to increase the strength of the heart. We give this to patients sometimes in very small levels, but sometimes we want to get this medication started pretty quickly. So we would give them a loading dose. Then we have the dynamic equilibrium, which is the actual concentration of the drug that's going to reach the body. And that dynamic equilibrium is going to be affected by absorption site. Okay, we're going to talk about this, distribution to that site, biotransformation, which is metabolism, and then excretion. All right, so here it is. Dynamic equilibrium is going to be affected by absorption, distribution, biotransformation, and excretion. So you should know all four of these. We're going to talk about them in detail. So absorption is going to be the absorption of any medication is going to be affected by the route of administration. Okay, so for example, oral medications affected by the presence of food in the stomach. That's going to change how quickly we absorb a medication. Okay, so anytime we think about drug absorption, we know that that's going to, however that medication is administered, it's going to have an effect. Okay. So sometimes if we think if there's food in the stomach, then we have a lot more acid in the stomach. Okay. Which can cause the stomach to empty more slowly. And then it exposes the drug to a more acidic environment for a longer period of time. And then it doesn't work as well. Okay. Then we also have to think about the first pass effect. So the first pass effect is when a drug is given through the mouth, so a PO, oral medication, is then going to be absorbed from the GI tract, and it's going to be transported via the portal vein to the liver. Once it gets to the liver, it's going to be what we call metabolized. And what happens is that as a result of this, in some cases, some drugs only a small portion of that active drug is going to reach the systemic system and get to that, intended target tissue. So this is, again, first pass effect. Medications are going to be, metabolized in the liver, and then not all of that dose of medication is going to make it to the patient's system. And you definitely need to know what that means. All right, so what are some factors that affect absorption? So IV, none, okay? It's going to go right into the bloodstream, so we don't have to worry about it affecting our absorption at all. Thinking about intramuscular, well, there's a lot of different things that can cause how fast or slow a patient absorbs that intramuscular medication. Perfusion, blood flow, fat content, temperature, all those have an effect. Thinking of a subcutaneous injection, again, fat content, perfusion, blood flow, temperature. Oral, we have a couple more different things. So acidity of the stomach, how long it's sitting in the stomach, blood flow to the GI tract. Are there any foods in the stomach that interfere? Okay. I definitely want you guys to know that for your exam, those different factors. All right, so question. What factors can affect the absorption of a drug? And what factors should the nurse prioritize? The client's blood urea nitrogen and creatinine levels, the route of administration that has been prescribed, the client's liver enzyme levels, or the date on which the client began taking the medication. And the answer here is going to be B. So we know that the only thing that can affect the absorption of a drug is the route of administration. All right, so now we're going to talk a little bit about distribution. So distribution really involves the movement of a drug to the body's tissues, okay? So we have protein binding. This is where drugs are going to be bound to proteins in the blood to be carried into our circulation. Then we have the blood-brain barrier, which is a protective system of our cellular activity, and it keeps different things away, mainly foreign invaders and poisons, from our central nervous system, okay? So usually drugs that are highly lipid soluble are more likely to pass through that blood-brain barrier and get to our central nervous system. And then thinking of our placenta and our breast milk, many drugs that we give are very quickly easy to pass through the placenta and can affect that developing fetus in our pregnant women, okay? So drugs should only really be given to pregnant women when the benefit clearly outweighs the risk. All right, so biotransformation, you guys definitely need to know this. So this is where this happens in the liver, and this is the most important site for biotransformation or metabolism. So metabolism is the same thing as biotransformation. So the liver is, it's going to be this process of where medications go through it, and then they're going to be changed into new, less active chemicals. So you can kind of think of the liver more as like a sewage treatment plant, okay? Everything that's absorbed from the GI tract is going to enter into the liver to be treated, and then the liver is going to detoxify a lot of those chemicals and use other chemicals to produce those needed enzymes and structures. It breaks down the medications, okay? And it helps prevent medications from causing adverse effects on the body, but we need to think about this when we're prescribing certain doses of medication because we have to take this into effect. Excretion, you absolutely want to know excretion as well. So excretion is going to be the removal of any drug from the body, okay? So the skin, the saliva, our lungs, our bile, our feces, urine, the kidneys are going to be different routes of how we excrete drugs. The kidneys themselves play the most important role in drug excretion, okay? So we should always think about a patient's kidney function and urine acidity before administering a drug, because kidney dysfunction can lead to toxic levels of any type of medication building up in the body, okay? All right, half-life. Definitely need to know what half-life is for your exam. So what is half-life? Half-life is going to be the time it takes for the amount of a drug in the body to decrease to 1/2 the peak level, okay? You will have to calculate a half-life problem on your exam. You should understand that half-life is going to be affected by absorption, distribution, metabolism, and excretion, okay? And that really makes sense based upon all that we just learned about those 4 things. So this information is also very important in determining the appropriate timing for a drug dose, okay, or determining the duration of a drug's effect on the body. So if we have a medication that is going to need to be given every 8 hours, we were able to determine that we could give that medication every 8 hours because we know what the half-life is, and we know how long it takes for half of that medication in the body to decrease to 1/2 the peak level. So we use the half-life to definitely determine the appropriate timing of a drug, but also think about maybe an older patient that has kidney failure that took a medication that she's having a bad effect from. We could anticipate that if her kidneys aren't doing well, that she might continue to have that bad effect from that medication for quite a while, several hours, maybe even days, until it's fully excreted from the system. All right, so this is, I grabbed this from your book. You don't really need to know this for your exam, but it does kind of explain what half-life is. And this is how we break down what the half-life of a drug level is, okay? So you have a patient that's taking a drug. The drug that we're giving the patient has a half-life of 12 hours, okay? We are trying to determine when a 50 milligram dose of this drug will be gone from the body. So we know it has a half-life in 12 hours. So in 12 hours, half of that medication dose is going to be left in the body. So all we have to do is keep cutting this dose in half. So if we started out with 50, we know that in 12 hours, half that medication is gone. So now we have 25, okay? Now we're going to go another 12 hours, okay, which would now be 24 hours because 12 and 12 is 24. So now we're going to take that 25 and break it in half again. So every 12 hours, we're going to break this medication down half of what the original starting dose was, okay? So 50 milligrams, we're going to break it down in 12 hours to 25. In another 12 hours, we're going to break it down, take that 25 and break it down to 12.5. If we went another 12 hours, which means we are now 36 hours, we're going to break that 12.5 down, and that would leave us with 6.25. After 48 hours, which is another 12 hours, we're going to take that 6.25 and break it in half, and that would leave us with 3.125. After 60 hours, we would have take that 3.125 and divide that in half, and that would leave us with 1.56 milligrams. So you see what we're doing here, okay? So basically, it would take 4.5 to 5 days to clear this drug completely from the body, okay? So there's a lot of different practice online that you can get to practice half-life and how to break it down. We will also practice this in class. We're going to do some problems. And once you practice it and do it a couple times, it's absolutely going to make sense. So here is a problem for you to practice, okay? So I'll let you guys do this on your own. The correct answer here is going to be C, 31 milligrams. And we can talk about this when we meet again for lecture. So what are some factors that influence the drug's effect? A lot of different things to keep in mind. So weight. We know that most recommended doses of a medication are targeted towards that 150-pound person, okay? People who weigh more require large doses. People who weigh less are going to require smaller doses. And then we know that in our pediatric patients, there's a very high probability that we're going to have toxic effects if they're very, very small. Age is really just a factor in our children and our older adults, okay? So children metabolize medications very differently than adults do, and they have very immature systems for handling different medications. Adults, however, develop a variety of different physical changes as part of the aging process, and they're more likely to take more medications for a lot of different conditions, and then their body's going to be responding differently, okay? Gender, there's physiological differences scientifically between men and women that can influence a drug's effect, okay? So, for example, when we're thinking about giving IM injections, it's always important to remember that men have more vascular muscles, so the effects of that drug will probably be seen sooner than in men than in women. Different physiological effects like electrolyte balances, acid-base balances, how well we're hydrated. We definitely have pathological factors as well. Renal dysfunction, we think about excretion, are our kidneys working? We think about metabolism in our liver. What if we have liver failure? What if we have something going on with our GI issue? Things like that. Genetic issues, some people actually lack certain enzymes that our system needs to be able to metabolize that drug, okay? Other patients may have a very overactive enzyme system that causes those medications to be broken down a lot sooner. We have different immunological factors, so thinking about allergies, so different people can develop allergies to medications, okay? It can be a very mild sensitivity, or it could be more severe like anaphylaxis and even death. Then we have different psychological factors as well. So really what science has told us and different studies have told us is that a patient's attitude about a medication really has been shown to have an effect on how that drug works. So a drug is more likely to be effective if the patient thinks it will work than if the patient believes it will not. Okay, this is called the placebo effect. So patient's personality also influences the compliance with that drug regimen. So there are people who believe that they can influence their health and be healthy and actively seek health care and, very willingly follow a prescribed regimen. Other people do not trust the medical system and they may not, be compliant with prescribed therapy. Different environmental factors as well. The environment can affect the success of drug therapy. So some drug effects can be enhanced by quiet, a cool environment, a non-stimulating environment. Thinking about drug tolerance, our bodies can definitely develop a tolerance to some drugs over time, which means that we would need to increase the doses that we give in order to achieve that same therapeutic dose. And a lot of our opioids for pain relief work just that way. Then we have accumulation effects. So if we have a medication that is taken in successive doses at intervals that are shorter than recommended, then the body is not going to be able to eliminate that drug and it accumulates in the body. And then we worry about toxic levels and adverse reactions. All right, so sometimes we have medications that interact with each other, okay? So this can happen anytime there's two or more drugs that are taken together, and they can occur at a variety of different ways. So definitely at the site of absorption, during distribution, during that biotransformation, and then during excretion. Our drugs can interact with certain foods, okay? We can have a drug-food interaction when the drug and the food come in contact with each other in the stomach. Whenever we eat something, it causes our acid in our stomach to increase in production, which is then going to speed down how quickly that drug breaks down, and it prevents absorption and distribution of the drug. So that's why we say that most drugs are best to be taken on an empty stomach. And then we know there are certain medications that can alter different lab tests, okay? So because of this, we may, thinking about administration of a certain medication, we may have to not give a medication before we do, certain lab tests. All right, what plays the largest role in drug excretion? So your answer here is going to be B, the kidneys. When administering a drug, the nurse understands that a drug administered by which route would be absorbed most rapidly. And we know this is C. The intravenous route is always going to be the quickest. And which phrase accurately describes the concept of a medication's serum half-life? The time required for IV medications to penetrate the brain tissue, the time needed for the serum level to fall by 50%, the safest margin to prevent toxicity, or the dose adjustment that reduces the risk of adverse effects by 1/2. And the answer here is going to be B. This is the time needed for the serum level to fall by 50%. All right, so moving along, now we are going to talk about toxic effects of the body. So what is the definition of an adverse reaction? So like we said, an adverse reaction is going to be an undesired effect, okay? It can be just mild and unpleasant, or it can be dangerous, okay? They can occur for a variety of different reasons. It could be that the drug may have other effects on the body besides that therapeutic effect. It could be that the patient may be sensitive to that medication that we're giving. It could be that the drug's action on the body is causing other responses that are undesirable or unpleasant. Or it could be that the patient is taking too much or too little of the drug that's leading to adverse side effects. So as the nurse, we frequently administer medication, so we have to constantly be alert for drug reactions of various different types. And we also have to teach families and patients what to look for when they're taking these drugs at home. Because remember, we want them to be compliant with medications, but we also want them to be safe. So for example, when we give patients antibiotics will disrupt the good flora that we have in our gut, in our belly, okay? When this happens, it leaves our system more susceptible to developing awful, very contagious liquid stools. We call this C. diff, okay? So are antibiotics good for patients that are sick, that have infections? Absolutely, and they need them. But is getting this, chronic, highly contagious diarrhea ideal? No. So we want to educate our patients that if they're taking an antibiotic, that they should do things that put good flora back into the belly, something like having yogurt with your lunch or taking a probiotic. Okay, that's a good example. All right, so when we think of the types of reactions that we can have primary actions. So primary actions are going to be one of the most common types of occurrences that we see in drug therapy. And this could be the development of an adverse reaction from a simple overdose, okay? So in some cases, what happens is that the effects are merely just an extension of that desired effect, okay? So, if we give a patient an anticoagulant to keep their blood thin, it may work so effectively that the patient has excessive spontaneous bleeding, okay? Secondary actions are going to be drugs that produce a wide variety of effects in addition to that desired pharmacological effect. So sometimes the drug dose can be adjusted so that the desired effect is going to be achieved without producing an undesired secondary reaction. Okay, so examples here. Antihistamines are very effective in drying up secretions and helping patients breathe. Okay, if they have allergies, we use them for allergies, but they also cause drowsiness. So a patient who's taking antihistamines needs to know that driving a car or operating heavy machinery or power tools, that this should probably be avoided when taking this medication, because then that drowsiness can be dangerous. Okay. Hypersensitivity. This is going to be, some of our patients are excessively responsive to either the primary or the secondary effect of this drug. Okay. So for example, many drugs are going to be excreted through the kidneys. So a patient who has kidney problems may not be able to excrete the drug, and it can accumulate in the drug and cause very toxic effects. All right, so different types of drug allergies. So we definitely need to know this slide. So a drug allergy can occur when the body forms antibodies to that particular drug. When that happens, it causes an immune response when the person is then re-exposed to that drug. Okay, so drug allergies are going to fall into 4 main classifications. So we have anaphylactic, cytotoxic, serum sickness, and delayed reactions. And you have this chart here that's going to break down each of them for you. What we need to know as nurses is that we need to be alert for any indications of an allergic reaction, because we know that maintaining client safety during drug therapy is one of the main things we do, okay? And then we have to make sure that we're educating our patients about those adverse side effects. So very, very important. All right, drug-induced tissue damage. Drugs can act directly or indirectly in the body and cause a lot of different adverse effects in our tissues, in our structures, and also our different organs. All right, so dermatological reactions. So this is going to be rash, hives, definitely something that we see in the skin. Okay, so these are any type of adverse reactions that involve the skin. It can be just very simply a mild rash, or it could be a very potentially fatal, some type of a dermatitis. Okay, so we could see just different types of abnormalities in the skin, red areas, raised red areas. We could develop blisters, okay? We can see a lot of different things. What might we need to do if we have this happening? Well, we might have to discontinue the medication, okay? Sometimes in mild cases, when the benefit outweighs the risk, we can just provide, frequent skin care. We can just give them specific instructions, things they can take over the counter. But in severe cases, obviously, we have to stop the drug and then notify the prescriber or the primary caregiver, okay? Stomatitis is something that can happen. This is an inflammation of our mucous membranes, and this can occur because we had a direct toxic reaction to that drug, or because the drug deposits in the end capillaries of those mucous membranes, and this is going to cause inflammation. All right, so what can we do? So what would we see with this? First of all, we might see swollen gums, inflamed gums, swollen tongue, red tongue, difficulty swallowing, bad breath, pain in the mouth and throat, a lot of different things. So what can we do for these? We can provide frequent mouth care, okay, with some type of a solution that's not going to be irritating. And then we could offer some type of a nutritional evaluation, okay, if it has something to do with their diet, and then even recommend them to have a dental consultation if that's necessary as well. All right, so we said that we worry about drug-induced tissue and organ damage. So we worry about superinfections, okay? Superinfections are going to be destruction of that body's normal flora. So what would we see with these patients? So we would see fever, diarrhea, vaginal discharge. These are some of the common superinfections that we see. So what would we do for these? We would be monitoring for fever, okay? We would be trying to prevent diarrhea, so we would be definitely giving our probiotics. We could just discontinue this medication if we had to. If they get some type of stomatitis from this, we're going to use some type of medication to help the symptoms in the mouth, do the frequent mouth care. But you should know that superinfections are going to be that destruction of that body's normal flora. And this happens a lot with our antibiotics. Some patients will develop a blood dyscrasia. So a blood dyscrasia is a bone marrow suppression that's caused by drugs. Okay, when this occurs, this is going to happen because these are drugs that can cause cell death. So a lot of our cancer medications cause this, and some of our antibiotics as well. So a lot of our bone marrow cells will multiply very rapidly. So we say that these cells rapidly turn over. So because they go through cell division and multiply so often, that makes them highly susceptible to any type of agent that is going to disrupt cell function. So what would we see with this? These patients may have fever, they may have chills, they may say they have a sore throat, they may feel weak, they may have back pain, dark urine, the kidneys aren't working, we might have anemia. Okay, so what are we going to do for these patients? We might monitor their blood counts. We want to know if their blood levels are low. We want to know if their white blood cell count is increasing and, they're developing a potential infection. And we might have to put them in protective isolation to protect their immune system. All right, the liver. So sometimes the liver can be damaged as well. We said that our drugs are going to pass through the liver in that first pass effect. So this exposes the liver cells to full impact of that medication before it's broken down and then put into the circulation of the body. And most drugs are metabolized in the liver. So we need to be aware if our patient has liver issues. So some of the assessment signs that we may see, these patients may have fever. They may develop nausea. They may develop jaundice, which is where the skin turns yellow. They may have a change in their color of their urine or their stool. And if we looked at their liver enzyme levels, they might be elevated. So for these interventions, these would be reasons to discontinue the medication completely. And then looking at our kidneys, we would see changes in urinary pattern. Maybe they're peeing more frequently. Maybe they're not peeing enough. And then if we looked at our kidney and labs, we would look at bun and creatinine. If these things were elevated, this would tell us that the kidney is being damaged. Okay, so what interventions would we do here? Well, we would notify the physician. We may need to hold the medication. We may need to stop the medication altogether, or sometimes we can just decrease the dose. You'll see a lot of different things. Poisoning is going to occur when there is an overdose of a drug that damages multiple body systems, okay? We should always understand that whenever we damage multiple systems inside the body, this can cause fatal outcomes. All right, so sometimes we may give medications that alter our glucose metabolism. Okay, so we know that we need glucose for energy, and that our central nervous system is especially dependent on constant glucose levels in order to function properly. Okay, so sometimes patients can develop hypoglycemia or hyperglycemia. So we might have to give medications for this. So if we have hypoglycemia, which is where our serum blood level, and again, remember our serum is our circulating blood, their blood sugar would be low. So how would we bring their blood sugar up? We would we would give glucose to their body by giving them something called D50. Okay, if they had hyperglycemia, this would be high serum glucose levels in the body, then we would administer medications like insulin to bring that glucose level down. All right, sometimes patients have electrolyte imbalances. So potassium is one of the main electrolytes that can cause big problems in the body. So if we don't have enough potassium, our patients would have hypokalemia, okay? So this would be a decrease in potassium levels. And what we would do for this is to replace that serum potassium. We could either give it IV or by oral supplements, and then we're going to continue to monitor these labs to see if we've corrected it enough, or if we have to give more, or maybe we've given too much and we don't want to give any more. And then if they have hyperkalemia, this would be an increase in our serum potassium level. So for this, we would decrease our serum potassium concentration by giving something called sodium polystyrene sulfonate. And this is a medication that we give that would cause our patients to have frequent bowel movements, which would then the potassium would bind to the stool and it would be excreted in the stool. And then, of course, we're going to monitor our serum levels of potassium. And we're also going to monitor for our heart rhythm. So whenever you think about potassium, you know that it affects the muscles, okay? It affects the muscles in the body. Our heart is a muscle, so it can also have an adverse effect on our heart. So it's not uncommon that if our patients have alterations in potassium, they'll be on a heart monitor, okay? Ocular toxicity and auditory damage can also happen. Okay, so ocular toxicity, patients are going to complain of visual changes. So sometimes if we know our medications cause visual toxicity or auditory damage, we would assess their baseline visual and hearing before giving the medication so that we have a baseline so that if anything changes, we know it's caused by the medication. Okay, so for visual changes, that ocular toxicity will monitor for any visual changes when giving the medication and discontinue that medication after notifying the physician. Same thing with auditory damage. We would monitor for hearing loss and then discontinue that medication and notify the physician if decreased hearing is noted on that assessment. We also can see neurological effects. So we can see effects on our central nervous system. And whenever we think about our central nervous system, this is going to be where we would see patients that have an altered level of consciousness. Okay, so we did say earlier that the brain is fairly well protected from the effects of many drugs by that blood-brain barrier, but some drugs do alter that neurological functioning. So what are some of those CNS effects that we may see? Could be confusion, could be delirium, insomnia, drowsiness, having hyperreflexia, bizarre dreams, hallucinations, numbness, tingling. So thinking about those symptoms that we may see, as the nurse, we are always going to be prioritizing our safety interventions, and we're going to be monitoring this patient to prevent any type of an injury. Then we have medications that are going to cause atropine-like effects in the body. Okay, atropine-like effects are also considered anticholinergic effects. So these are going to be medications that block the effects of our parasympathetic nervous system by directly or indirectly blocking those receptor sites. Okay, so atropine is a medication that we use preoperatively to dry up secretions. Okay. Most of our cold remedies and our antihistamines have anticholinergic effects. So what assessment findings would we see? We would see dry mouth, urinary retention, blurred vision. So our interventions would be to use those sugarless lozenges to keep the mouth moist, make sure that the patient is voiding before administration of the medication, okay? Help them to have bowel movements because we're worried about constipation, give them, increase their fluids, making sure that they're staying mobile, things like that. Some of our medications can cause Parkinson's-like effects, okay? So these are drugs that affect the dopamine levels in the brain that can cause a syndrome that resembles Parkinson's disease. Many of our antipsychotic or neuroleptic drugs cause this. So in most cases, they will go away when we withdraw the medication. And then something called neuroleptic malignant syndrome is something that we find we would see what we call extrapyramidal symptoms in our patients. So extrapyramidal symptoms are going to be caused by a drug that has an effect on our central nervous system. Okay, so we might see these patients develop with a very, very high fever if not treated quickly. So we would want to discontinue these medications right away. So these patients might have a fever, very high blood pressure, hypertension, very high heart rate. So we would want to discontinue these medications. All right. An example of a drug allergy is a dry mouth occurring with an antihistamine, increased urination with use of a thiazide drug, breathing difficulty after an injection of penicillin, or urinary retention associated with atropine use. And the drug allergy is going to be C, breathing difficulty after an injection of penicillin.